Good morning, everyone. Today I'm going to take a class on odontogenic keratocyst. So, odontogenic keratocyst basically is a it's basically a benign cyst of the lesion. This is in NIKHIL in 1876. It's termed as dermoid cyst. Huner in 1926 is as a colosoma, and Philippines in 1956 is named as OKZ. And Share in 1960, there's a predominant cyst. It's also called as a predominant cyst. Share in 2003 is again changed the name into keratocystoma. Richard in 2004 is claimed that it's a odontogenic keratinizing cystic odontogenic tumor, KZOT. Okay, in Philippines in 2006, again converted into keratocystic odontogenic tumor. Okay, KOT, reclassification of OKZ into cyst and tumor. It came in the JGCA in 2018. Moving on to the pathogenesis, the dental lamina, or it came from the dental lamina or its dental remnants. Okay, proliferation of the basal cell of the oral epithelium. Clinical features basically is incident into 3 to 11% of the odontogenic cyst. Age is basically bidomal peak, and sex basically male. Site is a mandible and angle ascending the ramus. Symptoms basically pathological fractures, painless swelling, discharge, paresthesia, and the lower of the lower lip or the lower teeth, and with the displacement of the teeth and the anterior and posterior expansion. Aspirate, you will get an odorless or creamy or cheesy content. And moving on to the radiographic features, is a well-rounded, oval or well-corticated radiolucency, sometimes with a large expansion or a scalloped and multilocular radiolucency. You can see displacement or unerupted or impacted tooth, displacement of the unerupted or impacted tooth in the inferior alveolar canal. Cortex may be perforated. Epicenter is above the inferior alveolar canal. It grows along with the internal aspect of the jaw with the minimal expansion. The radiolucency of the mandible is a pattern-based approach to the diagnosis. Radiographical type, this is a different kind of radiographical type. So one is a follicular cyst, which is surrounded with the crown and unerupted tooth, and is attached with the neck of the, it is attached on the neck of the tooth. Envelopmental type, it's enveloped in an adjacent impacted tooth. Replacement, which is place of the normal tooth. And collateral type, it's an adjacent to the root and similar to the lateral periodontal cyst. Based on the histology, so there's a two type of OKG. It's a parakeratinized and orthokeratinized. Most of the time, parakeratinized is 30% of the things are parakeratinized. It's aggressive and high rate of reoccurrence. And syndrome is associated with the OKZ is a nevoid basal cell carcinoma syndrome and Marfan syndrome, Ehlers-Danlos syndrome, and Newman syndrome. Differential diagnosis, basically the first differential diagnosis is ameloblastoma, second one is a residual cyst, and third one is a odontogenic myxoma, fourth one is a traumatic bone cyst, and fifth one is a denticular cyst as a main differential diagnosis. Moving on to the management part, what is the management? Enucleation is the first line of treatment, then the marsupialization. Peripheral osteotomy is another management part. Osseous resection, chemical cauterization, and decompression. The recurrence of the OKZ is the presence of a satellite cyst, a thin epithelial lining, intestinal growth, and potential to the proliferation of the basal cell. Thank you.